Welcome to the deep dive. We're here to really unpack complex health topics and turn that information into something useful, something empowering for you. Today, we're focusing on abdominal aortic aneurysms. You might hear it called AAA. Our goal is simple: give you the clear understanding you need, whether it's for yourself or someone you care about, so you feel, well, more confident talking with your doctor or healthcare team.
Exactly. And let's break down what a AAA actually is. Think of it like this. Your aorta is the main pipeline carrying blood from your heart down through your body. And AAA is basically a weak spot, a bulge in the section of that pipeline that runs through your belly area, kind of like a weak spot ballooning out on a garden hose. Over time, that bulge, that weakened area can get bigger, but, just understanding what it is, that's a huge first step. It really helps you feel more in control.
That's a great way to put it. And the information we're sharing today, it comes straight from the latest guidelines put together by vascular surgery experts. So this is reliable stuff meant to help you have those really productive conversations with your own medical team.
Absolutely. It's about having the right information.
Okay, so let's dive in. Where do we start? Maybe who is most likely to develop in AAA? What are the risk factors we should know about?
Right. Well, it's quite striking, actually. While lots of conditions have many different causes, with AAA, there's one factor that just stands way out: smoking.
Smoking, really?
Yes, overwhelmingly so. It's estimated that something like over 90% of people who get diagnosed with AAA have smoked tobacco at some point. It's a massive link.
Wow, 90%. That's huge. Does quitting help immediately, or is it more about long-term reduction?
Quitting helps almost right away in terms of starting the process of reducing risk, and that benefit grows significantly over time. It's probably the single most impactful thing someone can do.
Okay. So smoking is number one. What else plays a role?
Well, age is definitely a factor, especially being over 65. It's also more common in men than women. And family history matters, too. If a close relative, like a parent or sibling, had in AAA, your risk is higher.
So some things you can't change, like age or family history.
Exactly. But that doesn't mean you're powerless. General healthy habits, a balanced diet, staying active, they always support your overall blood vessel health, which is relevant here, too.
Okay, that makes sense. So knowing the risks is one thing, but how do you actually find out if you have in AAA, especially since they often don't cause symptoms early on? Screening seems key here.
Screening is absolutely crucial. It's our best tool for catching these early, when they're small and much easier to manage. Think of it as an early warning system.
And who should be getting screened?
The main recommendation is for a one-time ultrasound screening. It's simple, painless, non-invasive. It's especially recommended for men and women who are between 65 and 75 years old and have ever smoked tobacco, even if you quit years ago.
Okay, 65 to 75 with a history of smoking. Anyone else?
Yes, also for people in that same age range who have a first-degree relative again, parent or sibling who had in AAA, that family link is important.
Got it. A simple ultrasound. So if the screening does find an aneurysm, what happens next? Does everyone need surgery right away? I imagine that's a big worry for people.
That's a really important question, and no, absolutely not everyone needs immediate surgery. It really depends on the size of the aneurysm. For smaller ones, typically less than about 5 centimeters in diameter, the usual approach is what we call surveillance.
Surveillance, so like watching it.
Exactly. It means keeping a close eye on it with regular checkups and imaging, usually more ultrasounds or sometimes a CT scan. The frequency depends on the size. For instance, if it's around 3 to 4 centimeters, maybe check every 3 years. It gets closer to 5 centimeters, maybe every 6 months.
Okay, so watchful, waiting for the smaller ones.
Oh, yeah.
But what if it's larger or growing quickly? Then what?
Right. For larger aneurysms or those showing significant growth, that's when we typically talk about treatment to prevent it from rupturing. There are two main procedures. One is called EVR, that stands for endovascular aneurysm repair. The other is traditional open surgery.
EVAR endovascular. That sounds less invasive.
It generally is. With EVAR, we use catheters, usually inserted through small openings in the groin, to place a stent graft inside the aorta. It's like lining the weakened part of the pipe from the inside to reinforce it. Recovery is often faster, hospital stays shorter. And importantly, studies show EVAR generally has a lower risk of complications or death in the short term compared to open surgery. We're talking maybe around 1.4% risk versus perhaps 4.2% for open surgery, roughly.
That's a significant difference. Is open surgery still done often then?
Yes, it's still a very effective option.
Yeah.
And sometimes it's actually the better choice depending on, the specific shape and location of the aneurysm or a person's overall health. It's a very individualized decision. Discuss thoroughly with your doctor.
This is all incredibly helpful information. It
Yeah.
feels much less intimidating when you break it down like that. So, just to wrap up, the big message here seems to be that yes, AAA is serious, but it's definitely manageable. Knowing your risks, getting screened if you fit the criteria, and understanding the different approaches, surveillance, or treatment that really puts you in a better position.
Absolutely. If you take away just a few things, remember, risk factor smoking is the big one. Quitting helps immensely. Age, male gender, family history also matter. Screening that one-time ultrasound, especially for smokers or former smokers aged 65 to 75, is so important. It's simple and effective. And treatment and surveillance, smaller aneurysms are watched closely. Larger ones have effective treatment options, including less invasive ones like EVR. It's not always immediate surgery.
Knowledge really is power here. So as you leave us today, maybe think about this. What's one question you can bring to your next doctor's appointment to feel more informed and engaged in your own health journey? Keep asking questions, stay curious. Thanks for joining us on the Deep Dive.